the Kanski lecture series, and this is the retinal vascular disease part 4. And in this part, we are going to study about the diseases, how to treat the diabetic retinopathy. So, we have discussed about the intravitreal injections, we were discussing lasers. Now, we will discuss how we will perform the laser. So first, very important is that you have to take the consent, informed consent. The patient should be advised that a PRP may cause a visual field defects of a sufficient severity to legally preclude driving a motor vehicle. However, most patients who start with a good vision are able to maintain their binocular visual field to a standard legally required in most countries. So what happened is that you do the peripheral retinal photocoagulation, and the periphery is being affected. So what is happening that there is a visual field deficit, and it can lead to the visual disability conditions, like you cannot even drive the motor vehicle. They should be aware that there is a risk to central vision because of developing or exacerbating macular edema, a risk that can be reduced by fractionating the treatment over 2 to 3 section that night, and color vision may be affected. So you know that macular edema, PRP, is associated with macular edema. So if there is an already present macular edema, it can exacerbate the condition, and one can even lose the central vision as well. The 5-year result of the DRCR.net Protocol S and Clarity study should be discussed, as the patient may choose to treat with ranibizumab or aflibercept instead of PRP. However, they should be made aware of the risk associated with repeated injections and the short-term nature of these studies. So you can always give the advice to patient that if you want to get the anti-VEGF treatment as well instead of PRP. So what happens if the patient has a coexistent diabetic macular edema? If actual or imminent central involving diabetic macular edema is also present, an anti-VEGF agent should be considered, because the PRP exacerbate the diabetic macular edema, so anti-VEGF agent should be considered. This may be used as monotherapy or as an adjunct to PRP. Alternatively, in a case of a clinically significant macular edema not involving the center of the macula and active PDR, laser treatment to the macula should be considered in addition to PRP. So, if the patient is not involving the center of the macula, so what you can do is you can perform the PRP with the macular laser as well. In such cases, the macular laser treatment should be carried out prior to PRP or at the same laser treatment session. Lens. A contact lens is used to provide a stable magnified fundus view. A pan-fundoscopic lens is generally preferred to a 3 mirror lens. So first you have to take a lens so that you can see the retina as well. So you can use a pan-fundoscopic lens or a 3 mirror lens. Some practitioners prefer to use a high magnification, smaller area contact lenses, mainstir area centralis, for most posterior component of the treatment. It is essentially to constantly bear in mind that inverted and laterally reversed images being seen. So you know that when you see the retina, the image is laterally reversed and inverted as well. Anesthesia. The amount of treatment it is possible to apply during one session may be limited to by a patient discomfort. This tend to be at least at the posterior pole and greatest in the periphery and over the horizontal neurovascular bundle, and may worsen with the successive session. So first you can give the anesthesia. It can be local anesthesia, or even you can give the subtenon or peripulbar anesthesia as well. So that this tend to be at least at the posterior pole and greatest in the periphery and over the horizontal neurovascular bundle, and may worsen with successive session. Topical anesthesia is adequate in most patients, although subtenon or peripulbar anesthesia can be administered if necessary. Laser parameter, so there can be spot size. So what are the settings we use during laser? So spot size is basically the size of the laser of the spot. So a retinal burn diameter of a 400 micrometer is usually desired for PRP. So 400 micrometer spot size is necessary. The diameter selected at the use interface to achieve this depend on the contact lens used. So it is dependent. Our required size is 400 micrometer, but it is dependent on the lens. Why? and the operator must be aware of the correction factor for the particular lens chosen. As an approximation, with pan fundoscopic lenses, the actual retinal spot diameter is twice that selected on a laser user interface. So, for example, if you on the pan fundoscopic lens, if you take a spot size of a 200 micrometer, but in actual it is basically 400 micrometer, because it is giving us a microfied view. 200, so that is why 200 micrometer is typically selected for PRV, equating to a 400 micrometer actual retinal diameter once relative magnification is factored in. With the main star and area centralis, the retinal diameter equally equate closely to the interface selected, so a 400 micrometer may be selected. So if you are using a main star and an area centralis lens, then a 400 micrometer can be selected. So what is the duration of the treatment? So duration depend on the type of laser. So most of the time one spot size is having a duration of 0.05 to 0.1 second. So the spot size 0.05 to 0.1 second was conventionally used with the argon laser, but new lasers allow much shorter pulses to be used for, and 0.01 to 0.05 second, 10 to 50 millisecond is the currently recommended range. Multi-spot strategies is available on some machine, utilizes a combination of a short pulse duration, very short interval, and pre-programmed delivery array to facilitate the application of a large number of pulses in a short period. So now there is a multi-spot technique, is like you are have targeted an area. So what is happening, that multiple spots will be projected and of a very short interval, and it will facilitate the application of a large number of pulses in short period. True sub-threshold PRP is also under investigation and show promising result. Shorter pulse duration seems to require a greater total number of burns for an adequate response and may be slower to achieve regression. So sub-threshold PRP is that you just take a pulse for a very short time and you take a longer interval. So this is basically for the minimizing the collateral damage, but in the case of a PRP, there is then a greater number of burns are being required, and they are slower to achieve regression. Power should be sufficient to produce only a light intensity burn. Spacing, burn should be separated by 1 to 1.5 burn width. So the distance between the two burn is almost 1 to so the 1 to 1.5 burn width, so almost 400 micrometer distance between them. So how the extent of area is being treated, the initial treatment session should be consist of 1500 burn in most cases. More may be applied if there is a risk of imminent sight loss from the vitreous hemorrhage. So you at the first treatment almost 1500 burns are being applied. The more extensive the treatment as a single section, the greater the likelihood of complications. But if you do more treatment, there are more likelihood of complication. Reported figures vary, but 25 to 3500 burns are likely to be required for a correction of a mild PDR, 4,000 for a moderate PDR, and 7,000 for the severe PDR. So depending on the PDR, if there is a mild, moderate, severe, then we can go for 3,500, then 4,000, then 7,000 for the severe one. The number of burns offer only approximate guidance, as the effective extent of treatment is dependent on numerous variables. Pattern of treatment. The treatment is generally restricted to an area outside the temporal macular vascular arcade. It is a good practice to delineate a barrier of a laser burn temporal to the macula earlier in the procedure to help reduce the risk of a accidental macular laser. Many practitioners have at least leave 2 disc diameter untreated at nasal side of the disc to preserve the paracentral field. In the very severe PDR, it is advisable to treat the inferior fundus first, since any vitreous hemorrhage will gravitate inferiorly and obscure the area, precluding further treatment. Areas of vitreomacular traction should be avoided. Retinal traction should be avoided. So how do you apply the laser? So this is area of the retina. So this is an optic disc, this is a temporal arcade. So you apply the burn almost periphery outside the temporal macular arcade. You apply inferiorly first, then superiorly, so that if any vitreous hemorrhage occur, it will gravitate downward, and then you treat the superior side. And then what happen is you treat almost 2 disc diameter away from the nasal side of the disc, so that the central vision is being preserved. Review is dependent on the PDR severity and the requirement for successive treatment application. Initial treatment should be fractioned over 2 to 3 sessions. Once an adequate number of burns have been applied, review can be set for 4 to 6 weeks. In a patient with a proliferative diabetic retinopathy and macular edema, first treat the edema, then undertakes the pan-retinal photocoagulation. Indicators of regression include blunting of the vessel tip, shrinking and disappearance of the new vessels, often leaving a ghost vessels or fibrosis, regression of irma, decreased venous changes, absorption of a retinal hemorrhage, disc failure. So how will you know that the new vessels are being regressing? So you will see that there will be going to be the blunting of the vessel tip, there going to be the shrinkage or disappearance of the new vessels, often leaving a ghost vessels or fibrosis, there going to be the regression of irmas, they're going to be the decreased venous changes, they're going to be the absorption of retinal hemorrhage, they're going to be disc failure. Contraction of the regressing vessel or associated induction of a vitreous separation can precipitate vitreous hemorrhage. Significant fibrosis proliferation can lead to tractional retinal detachment. So if there is a fibrous proliferation, it will cause the tractional retinal detachment formation. Patient should remain under observation as recurrence can occur with the requirement of additional PRP. So VEGF inhibition. So this is a wild field FA showing widespread area of a capillary non-perfusion. So this is a capillary non-perfusion area. So VEGF inhibition for a proliferative proliferative retinopathy. So what if there is a PDR and you are treating with VEGF injection? So according to the protocol S in clarity, the aflibercept have same effect as the as a PRP, and same clarity has a ranibizumab has the same effect as a PRP, and clarity shows that the aflibercept has same effect as a PRP. So drcr.net protocol S concludes that intravitreal ranibizumab treatment is as effective as PRP in a patient at high risk of PDR for up to 5 years. The macular edema rate is reduced and the visual field is slightly better maintained with anti-VEGF treatment. So basically it is saying that protocol S is showing that basically the intravitreal ranibizumab has the same effect as PRP at 5 years. And macular edema rate is reduced and visual field is slightly better maintained with anti-VEGF treatment. Irrespective of the therapeutic option, approximately half will appearance of vitreous hemorrhage over that period. Anti-VEGF treatment should be avoided, and PRP provided follow-up is likely to be poor of it is a cost issue. Treatment of rubeosis irides, treatment of PDR prior to cataract surgery. So sometimes the PRP is necessary because if you know that if the patient is unlikely to follow up and the cost is an issue, then you can always go for PRP. And it is also used for the treatment of rubeosis irides, and there is a treatment of PDR prior to cataract surgery. Targeted retinal photocoagulation (TRP) wide-field FA allows accurate delineation of a peripheral capillary non-perfusion. Selective treatment of these areas with scatter laser has been reported as effectively leading to regression of NV while maintaining minimizing the potential complication. So there is another thing which is known as a TRP, which is a targeted retinal photocoagulation. So basically it is according to fluorescent angiography we see that any areas of a capillary non-perfusion area, and we treat basically that area so that any potential complications are being avoided. So next is an advanced diabetic eye disease, which is basically consists of 3 things: neovascular glaucoma, next is tractional retinal detachment, and another thing is vitreous hemorrhage. So advanced diabetic eye disease is a serious vision threatening complication of diabetic retinopathy that occur in patients on whom treatment have been inadequate or unsuccessful. Occasionally advanced disease is evident as presentation. So what are the clinical features of advanced diabetic eye disease? Hemorrhage. Hemorrhage may be pre-retinal, retrohyalide, intraocular or both. Intraocular hemorrhage should be should usually take longer to clear than pre-retinal because the former is usually more substantial. In some eyes, altered blood become compacted on the posterior vitreous face to form an artery membrane. Ultrasonography is used in eyes with dense vitreous hemorrhage to detect the possibility of the associated retinal detachment. So, so you know that there is a hyaloid membrane in front of the retina, which is known as a hyaloid membrane. So the any hemorrhage which is basically uh, b- bef- uh, after this hyaloid membrane is known as a pre-retinal or retrohyaloid hemorrhage, and if there is an in the vitreous, it is known as is intragel. So both can also be present, and it will happen that intrajal hemorrhages are more likely that they will get a longer time to get clear. And in sometimes when there is a dense vitreous hemorrhage, you perform the B scan ultrasonography so that you can see that if there is any case of the fractional retinal detachment within. The tractional retinal detachment is caused by the progressive contraction of the fibrovascular membrane over the areas of a vitreoretinal attachment. So you know that there is an area of a vitreoretinal attachment. So whenever there is a fibrovascular membrane formation, the contraction of in the diabetic retinopathy, whenever there is a contraction of the fibrovascular membrane, it can cause the retinal detachment, which is basically due to contraction. Fibrosis, posterior vitreous detachment in eyes with PDR is often incomplete due to strong adhesion between the cortical vitreous and the areas of a fibrovascular proliferation. Hemorrhage often occur at this site due to the stress exerted on NVEs. So you know that posterior PVD is incomplete in a case of a diabetic retinopathy and tractional retinal detachment. Why? Because you know because the cortical vitreous and the fibrovascular proliferation has a strong adhesion. So when so the in a case of when the fibrovascular membrane and the vitreous having a strong adhesion, so what is happening that it will not detach from that part of the area, so the PVD will be incomplete. Dubious arthritis arrests neurovascularization. NVIs may occur in a patient eyes with PDR and if severe may lead to neovascular glaucoma. NVIs is particularly common in eyes with severe retinal ischemia or persistent retinal detachment following an unsuccessful pars plana vitrectomy. So NVIs can occur because there is a lot of angiogenic factors are being released, so the iris will also get the neovascles formation. Indications for the pars plana vitrectomy. So what are the indications you do in the pars plana vitrectomy? Vitrectomy in diabetic retinopathy is typically combined with extensive endolaser PRP. um, so you do perform pars plana vitrectomy. After that you perform the endolaser. Visual result depend on the specific indication for surgery and the severity of the pre-existing disease. Severe persistent vitreous hemorrhage. So if there is a vitreous hemorrhage which is there with the which is persistent, it is known as it is an indication for PPV. Severe persistent vitreous hemorrhage that precludes adequate PRP is the most common indication. In the absence of a rubeous iritis, vitrectomy has traditionally been considered within the 3 months of a initial vitreous hemorrhage in type 1 diabetes and in most cases of a bilateral hemorrhage. So we do it if there is a bilateral hemorrhage and if there is a vitreous is not getting cleared even after 3 months. However, the outcome may be better with earlier surgery and availability of the intravitreal anti-VEGF therapy may further modify the approach. So in a case of a progressive tractional retinal detachment, so the thing is progressive retinal detachment word is very important because TRD is mostly stable if it is not threatening the macula, and if it is in the periphery then you tend to just observe it. But if the TRD is becoming progressive or is involving the macula, then we go for the PPV. Progressive tractional retinal detachment threatening or involving the macula must be treated without delay. However, extramacular detachment may be observed since they are often remain stationary for prolonged period. Combined retractional and rhegmatogenous retinal detachment should be treated urgently. So, if there is combined TRD plus RRD, we should be treated urgently. Next is a pre-macular retrohyalite hemorrhage. If tense and persistent, should be considered for early vitrectomy because if untreated, the internal limiting membrane or posterior highlight phase may serve as a scaffold for subsequent fibrovascular proliferation and consequent fractional macular detachment or macular epiretinal membrane formation. So if there is a retrohighlight hemorrhage, which is basically pre-macular, then you treat it with macular PPV because it can lead to fractional macular detachment or macular epiretinal membrane formation. But the most thing is that dispersion with the handy-gag laser hyalotomy is also unsuccessful. Anterior segment neovascularization and media opacity, which prevent visualization of the posterior pole, should be considered for vitrectomy and intraoperative laser therapy. So, if there is a very media opacity is an anterior segment neovascularization, we can go for PPV as well. Tip resistant vitreous hemorrhage or progressive retinal detachment threatening the macula should be treated as soon as possible with the pars plana vitrectomy. Then there is a diabetic papillopathy. Diabetic papillopathy means that there is a optic disc edema with diabetes. Diabetic papillopathy, diabetic papillitis, has been suspected to be uncommon variant of an anterior ischemic optic neuropathy, though it is more commonly bilateral. So it is mostly bilateral and tend to exhibit more diffuse disc swelling. And diffuse disc swelling, the underlying pathogenesis is unclear, but it may be the result of the small vessel disease. It occurs mainly in a younger diabetes and manifests with mild painless visual impairment that is unilateral in more than half of the cases. So the young diabetic patient will present with it. Bilateral disc swelling mandates the exclusion of the raised intracranial pressure. So one should always exclude the raised intracranial pressure. Hyperemic disc swelling is characteristic and disc telangiectasia, occasionally mistaken for neovascularization, is present in many affected eyes. So hyperemic disc swelling, and there is a disc telangiectasia. Crowding of the pallor disc may be present. Resolution may occur over several months, often leaving mild disc pallor. Final visual acuity. Visual acuity is 6 by 612 or better in 80%, subject to the effect of a coexisting diabetic retinopathy. So the final visual acuity is usually 6 by 12 or better in 80% of the subject with a coexisting diabetic retinopathy. Distinction from the retinal vein occlusion type papillophlebitis rests on the presence of more extensive retinal hemorrhage and venous congestion in the later, but may not be possible. So in a case of a RVO containing edema, the extensive retinal hemorrhages are more extensive and their venous congestion are more present. Intravitreal anti-VEGF agents and steroids via rust have been tried with indeterminate benefit. So intravenous agent and steroids can be tried. So this is an advanced diabetic eye disease. So you can see this is a retrohighlight and intragel hemorrhage. So there is a retrohighlight gel and there is a intragel hemorrhage. B is showing us the tractional retinal detachment, pre-retinal traction. So you can see that there is a fibrovascular traction. C is showing tractional retinal detachment. D is showing significant vitreous hemorrhage. Next is a non-diabetic retinopathy. Up to 10% of the individual over the age of 40 without diabetes exhibit mellitus exhibit usually very mild retinopathic features such as microaneurysm, dot plot hemorrhages, and cotton-wool spot that would be considered with consistent with the diagnosis of a diabetic retinopathy. So if the patient who are almost greater than 40 years old, up to 10% will show the diabetic retinotype feature like mild diabetic retinopathy feature like microaneurysm, dot plot hemorrhages, and cotton wool spot. Assuming that an alternative ocular cause such as RVO or idiopathic macular telangiectasia has been excluded, this non-diabetic retinopathy tends to be associated with increased cerebrovascular and cardiovascular risk and may be particularly prevalent in a patient with known or incipient hypertension. So sometimes when there is an RVO and other causes, idiopathic macular telangiectasia has been excluded, there is a then a non-diabetic retinopathy has been suggested, and it is most likely in a patient who are having a cardiovascular risk. There is an evidence suggesting that it may be the marker of a preclinical diabetes in some patient. Higher venular caliber may also denote this. So if the venous caliber is higher, it means that there is a preclinical diabetes. Appropriate management is undefined, though evaluation and optimal management of the systemic vascular risk factors may be prudent. The signs commonly disappear spontaneously, and this is more likely in those with lower level of a cardiovascular risk. So this is a large premacular retrohyaloid treatment hemorrhage. So before ND-YAG laser, after ND-YAG laser. So this is a retrohyaloid hemorrhage before and after the treatment of the ND-YAG laser. So this is showing hyperemic disc swelling and telangiectasias in diabetic papillopathy. So that's it for the part 4. See you in the next lecture.